our insights presentation, we're going to discuss risk adjustment. Determining risk determines reward. So what actually is risk adjustment? It's a tool that is used to predict healthcare costs, a process that involves reporting diagnoses, and it measures the patients on an equal playing field, and it also affects payment and quality outcomes of patients, and it's accounted for known and discovered health data elements and levels comparisons of wellness amongst patients. So when we talk about risk adjustment, it's heavily on diagnosis codes. However, there are some other determining factors that are involved. As many know, cost varies greatly from one patient to another. So again, the risk adjustment models levels the playing field when evaluating all patients that are being treated within a group or a health plan. Those additional elements that are taken into consideration when risk adjustments are being determined is age, gender, socioeconomic status, disability status, insurance status, such are they Medicare, do they have Medicaid, are they dual eligible? It also looks at claim data elements such as procedure codes submitted, place of services, and it also looks at those special patient-specific conditions. Are they enrolled in hospice? Maybe they're in a skilled nursing facility. Are they an end-stage renal disease patient? When we talk about risk adjustment models, there are 5 different risk adjustment models. Probably the most popular that most people are familiar with is the HCC, which is the Medicare Part C risk adjustment plan, the hierarchical condition category, but also Medicaid has its own plan, which is the CDPS, the Chronic Illness and Disability Payment System. For inpatients, it looks at diagnosis-related groups, or DRGs. For outpatient, it looks at adjusted clinical groups, and also with the Affordable Health Care Act, there is the HHS program, which is through the Health and Human Services, which is the hierarchical condition category. So for Medicare and their HCC program, it's utilized by Medicare Advantage plans. It's probably one of the most recognized risk adjustment models. It started back in 2004 with Medicare. It uses diagnosis codes and filters them into 79 different condition categories where hierarchies or families of conditions are placed to gain an HCC numeric code, which that translates into a risk adjustment factor. So how does risk adjustment affect you? Well, physicians, they're going to treat the patient that are on the risk adjustment funded models. The plans expect the providers to document and code diagnoses correctly. The physician documentation and coding establishes the complexity and workload of the patients, and the documentation and the diagnoses become the basis for the funding and the reimbursement for the patient. So how is a risk factor score developed? Well, the baseline for the RAF score is made up of elements, again, such as their age, their sex, are they dual eligible on Medicare and Medicaid. It looks at claims-based data, face-to-face encounters for qualified practitioners for the calendar year. So the work that's currently being done this year will be for the funding for next year. It looks at chronic conditions which do not change from year to year, such as your diabetes, your COPD, your CHF, atrial fib, and it assigns a value to each diagnosis code in the HCC category. The categories sometimes are infections, neoplasms, diabetes, substance abuse, cerebral vascular disease. Now, that's not all of them. That's just an example of some of them. Also, one thing to remember is that not all diagnoses carry a risk adjustment factor. Typically, what they look at is diagnosis codes that are costly to manage from a medical management or prescription drug treatment, and those are likely the ones that are to be found in the risk adjustment models. When we talk about risk adjustment, it's heavy on correct coding. We need to code diagnoses to the highest level of specificity as possible at all times. Documentation must be specific. We need to look at modifying factors. They should be clearly documented in the chart. We need to establish chronic versus acute, which also again needs to be clearly documented in the chart. Some of the commonly underdiagnosed conditions are hypertension and diabetes. Remember, no coding from problem list or super bills or medical history. So treatment is prima facie, evidence of a diagnosis. If you are treating, it exists. When we talk about chronic conditions, one of the acronyms that's used is MEET, monitor, evaluate, assess, and treat. So we need to report all diagnosis codes that are part of the medical decision-making for each visit. You need to monitor signs and symptoms, disease progression and regression, evaluate, such as what test results have you looked at for the patient? What type of medications are they on? Is that effective for the patient? How are they responding to the treatment? We're going to assess those chronic conditions. Do they need some tests? Are they a diabetic? Have they had their A1C drawn? You're going to review previous records from consulting providers, maybe provide some counseling to that patient, and then you're going to provide treatment to the patient. Are they on medication? Do they need refills? Do they need new medications? Are they going to need some type of therapy? Are there going to be other modalities of treatment? When we look at the risk adjustment and financials, this graph here is of the same 76-year-old female patient. And when you look at it from column to column, and gradually the more information that you provide, the yearly reserve for care gets higher. So when you look at the first category, it's just a 76-year-old female, they're Medicaid eligible, no diagnoses have been submitted. So their RAF score is 0.645, which is low, so they're only going to reserve $5,418. But as claims data is reviewed, diagnosis comes in, you can see over time how that $5,418 has now turned into $16,573. So again, health plans are funded based on risk adjustment factors. Undercoding can lead to underpayment and loss of revenue, and overcoding leads to audit risk and compliance actions. So one of the audits that are done by CMS is the risk adjustment data validation. Again, it's only used for Part C, which is your Medicare Advantage. It's done to verify the accuracy of diagnosis codes submitted. And the medical record must support the diagnosis codes. The provider signature needs to be valid, and the provider credentials are reviewed, such as MD, DO, PA, NP. And then supplemental diagnoses that maybe weren't originally submitted on the claim but have been reviewed can be approved if they are documented as current diagnoses in the record. The HCC model for the Health and Human Services, as we talked about a little bit ago, was part of the Affordable Care Act. For this particular model, it's a little bit different because patients are grouped by adult, child, and infant, and they're also grouped by metal of platinum, gold, silver, or bronze. This particular plan doesn't currently review prescription-based diagnoses, and the hierarchical grouping is similar to Medicare, but they select a different set of HCCs for the federal risk adjustment, and it reflects the population a little bit differently. When we discuss the ACA plan and the metals for The bronze plan, for example, generally has the lowest premium, but they also usually have the highest deductible. The platinum plan usually has higher premiums, but low deductibles and low out-of-pocket. The silver plan kind of gets the best of both worlds, with the premiums being low and the out-of-pockets being low. The catastrophic plans, they have a low premium, but the deductible is super high. When talking about Medicaid, their CDPS program, it uses 20 major disease categories. The level of risk is grouped in by very high, medium, low, or extra low. It utilizes history of and family history of codes. It has similar coding rules of those of the HCC Medicare plan, and it captures all current diagnoses and all known statuses. One of the things that Medicaid does do is it uses data from both claims and prescriptions. Also, when you look at the hierarchical value setting, low is trumped by medium, and medium is trumped by high. Here's an example of the 4 levels. So, for example, when you look at cardiovascular category, someone would be considered very high that may have had a heart transplant. Medium would equate to heart attacks. Low would be heart disease, and extra low would be hypertension. So why is HCC risk adjustment important? Well, it's important because it improves the quality of care through disease management, care coordination of the patient, its accuracy in member health status profile, and appropriate risk premiums from CMS. This is an example of CMS's risk adjustment payment schedule. So again, as you can see, the work that you do this year will be for payment for the next year. So the last possible final submission deadline for this year is January 31st, 2017. So how does MIPS and risk adjustment go together? Well, if 60% of the MIPS score for providers is going to come from risk-adjusted quality and resource, it's really important to accurately reflect the acuity of their patient population. So doing this will allow quality and cost scores to accurately reflect the excellent care provided by physicians. So with this being said, diagnosis coding is going to become so much more important, both for the fee-for-service and for risk adjustment. And Medicare does use the diagnosis data for risk adjustment under MIPS. So we here at CareOptimize, we are comprehensive value-based healthcare services. We have a managed healthcare partners, which is a full risk independent physician association. We currently have 100 active providers. We also have our CareMax medical centers, and that is a fully owned Medicare Advantage center. So we live and breathe the risk adjustment, day in and day out. We also focus on care coordination and preventative medicine. We also have our Care Alliance programs, CareOptimize, which is our consulting professionals, and CareOptical. So some of the benefits from the Care Holding Group Network. Again, we're a full risk proven model. We know the benefits because we use it every day. Our healthcare experts on our consulting side of things, they keep up with the latest healthcare information, all the technology. They know how to maximize revenue, optimize services. We have our all-inclusive healthcare services, from your basic needs to your specialized medicine. Also, we really focus on the value-based medicine, and our experience and capabilities result in increasing value while reducing costs. Here's an example from one of our risk adjustment facilities, and this is an example of a 79-year-old male, originally with a baseline premium of $710, but after adding diagnosis codes, you can see where his baseline premium went from $710 to $1,661.40. Our CareOptimize coding model, we integrate into the physician workflow, and it works inside the EHR. It can identify missed HCC codes. It also can improve the RAF score. It's real-time claim feeds from the payer. It looks at labs, notes. It can look for any missed coding opportunities. And the HCC codes billed in the past that may have not been recertified this year by a provider. So here are potential RAF scores, low, medium, high. And then here is a listing of patients. And if you look at Rachel Butler, you can see that she's a 55-year-old female. She has a projected RAF score of 3.485. With this model, you can tell that we've accepted 5 missed opportunities, and it may have an impact on her overall RAF score. Again, this is a screenshot here of a patient-specific, their overall diagnosis codes, and you will be able to see patients grouped, again, by the RAF score inside the EHR. By using this tool, you're able to uncover the diagnosis codes that have been billed, their HCC category, the last time that it was billed, and the last date of service that it was billed for. Also, it gives the overall risk score for the patient. And in conclusion, accurate risk adjustment coding will continue to increase in importance. And if you'd like any further information, please contact us.
Okay, thank you, Ashley. And that is it for our presentation. Please know that the recording of this webinar will be available very soon, within 24 hours.
Work with the rev cycle director.
Okay.
Huron is having difficulty with the fact that they are not owning the project any longer. That they are not the ones managing the project because they put in a bid for